Good afternoon, my friends. It is Wednesday again, and this is June 18th, and this is Dr. Velma Scanterbury, and I am here with you live for Dialysis Patient Citizens Educational Center. So I'm trying to get that light from behind my head, so trying to shift this a little bit. So how are you doing? Are you doing well? Is things going exceptionally well? We're now into the summer, and hopefully within a week or so, but we have had not the greatest weather, but you know what? I am thankful for every day that I can wake up and enjoy that day. So again, I am Dr. Velma Scanterbury, and I am here with Dialysis Patient Citizens Educational Center, and we are here to have a conversation. Thank you, Ken, for coming on, and Susie. Tell me where you are located. How are you doing? Are you a dialysis patient or are you post-transplant? My background is that I have spent years as a transplant surgeon and did my transplant training at University of Pittsburgh, was there for many years and moved on. So for me, it's been over, I would probably say a 30+ year career in transplantation, primarily kidney transplantation, doing both donors and recipients, living donors. And so it has been quite a career for me, and now I am in private practice. I'm actually taking care of patients on the primary care end, many of them on dialysis, thinking about kidney transplant, and most importantly, educating our communities about about chronic kidney disease, because chronic kidney disease is asymptomatic. Except you happen to have your creatinine checked or have noticed or someone told you about protein in your urine and follow through with it. So many patients are unaware that they are in stage 3 kidney disease. Many are diagnosed with stage 4 kidney disease because of the lack of symptoms. And so, again, if each and every one of us decide that we want to educate our communities and those where we gather, whether it's our place of worship, whether it's our community centers, whether it's our bingo games or our book clubs, we can begin to get the word out about checking your numbers. We check blood pressure, we check blood sugar, we want to know all those things, but we also need to make sure that we educate our families about checking your renal function and what's going on there. So again, thank you all for coming on. My name is Dr. Velma Scanterbury, and I am the consultant here for Dialysis Patient Citizens, and today is our Facebook Live. And for all of you who are watching, I see many of you have either, Ken, you've been on dialysis for 8 years prior to now you're doing well, and thank you for that. Transplant at Shreveport, Louisiana, 9 months ago. Wonderful. As many of you know, just as well as you get your transplant, your kidney will not necessarily last forever. Your body will see it as a foreign substance. With some patients, they can live in harmony for a long time. And they can, no matter whether they have an infection, whether they have something going on, nothing upsets that boat, and they do well. And there are others who can likely get that make kidney and be the exact opposite, where they constantly either have rejection, there's a slow smoldering chronicity that occurs over time, but you have to make sure. It's very important to get your lab work done on a regular basis and to follow through. If you're not seeing a transplant nephrologist or the transplant center, make sure that you are at least having your primary. Make sure you also have a primary, because you want to make sure that you're checking doing all your cancer screens, making sure your heart's good, and that all the other parts of you are also working well. Not if you've gone through all the trouble of being on dialysis, getting listed, and waiting for the ultimate gift, which is the gift of transplantation. So I thank you all for being here. And for many of you, if you're transplanted and have not reached out or written a letter to your donor family, I encourage you to do so. It's so very important. They may not respond immediately. They oftentimes may be interested in knowing what's the outcome. There are a few who don't really want to know, but it can often take donor families many months to even respond, or even years. But they actually may still treasure those letters. They may treasure those cards. And whether it's 5 years or 10 years or 15 years post that donation, then you definitely want to constantly send those cards, because they treasure them oftentimes. So question: if a patient receives a kidney from a cadaver and the person has hypertension or diabetes, will the recipient also get diabetes and or hypertension? Well, one of the things to remember is that diabetes and hypertension are the two leading causes of end-stage kidney disease. By the time you get to stage 5 and on dialysis, you're really struggling. That's the worst when it comes to high blood pressure. On dialysis, your medicines are regulated to try to keep that blood pressure under control. For some people it works, for others not. But after you get your transplant, you restore kidney function. If that kidney function is good, it should make it easier to control your blood pressure. You may not be stage 1 again, but you may be 2.5, depending on what your creatinine is. And with better kidney function, your kidney secretes renin. It should be easier to control your blood pressure. You don't necessarily get it from the donor kidney. It's all your underlying risk for high blood pressure, unless the donor kidney has renal artery stenosis or something that drives that kidney to make more renin, which is the hormone that increases your high blood pressure. As far as diabetes comes from lack of production of insulin, or lack of appropriate insulin that can be utilized by the body, and that's made by you, the recipient. You may develop diabetes because, one, you're triggered in more sugar or things that promote higher blood sugars, such as the steroids. Some of the immunosuppressions, tacrolimus, is known to result in post-transplant diabetes. So if you have more incidence of rejection, you may have more medications that increases your risk of having diabetes. So you want to be able to check your hemoglobin A1C. And so you may also have a gene factor within your own genetic makeup that puts you more at risk to become diabetic. So diabetes, in terms of your pancreas as a recipient not making enough, or your body not being able to utilize the pancreas, utilize the insulin you make, can be a combination of having an effect on some of the post-transplant medicines. So it's going to be related to that more so than it's not necessarily coming from the recipient. The only things you worry as far as that recipient kidney is you want to make sure you're not, which is why we check so often, virus infections, any infections that may be carried from the donor to the recipient. We check for EBV, CMV, BK virus that may be reactivated because of immunosuppression. So thank you. Parathyroid, please explain. Parathyroids are 4 little glands in your neck that sits above and below your thyroid, and your parathyroid secretes a hormone that causes you to make more calcium. However, when you have end-stage kidney disease, remember the metabolism is calcium and phosphorus. So with kidney disease, your phosphorus is always the one that's an issue. So your phosphorus goes up, your calcium goes down. So they have to be balanced. One, they both are similar ions. So you have too much phosphorus, too little calcium. Your body says you don't have enough calcium. Your parathyroid is the hormone. It's saying I need to cause you to make more calcium. So the parathyroid hormone goes up, secretes more PTH. Your PTH level goes up because it wants to drive your calcium level up and drive that calcium, which can be mobilized out your bones. As a result, that constant stimulation of your parathyroids, trying to make more hormone to keep your calcium level high, causes those cells to actually hypertrophy or get bigger. And one of those those four glands can actually develop an adenoma, which now becomes independent, and it begins not listening to the rest of your body's stimulus. So you may have all four of them may be enlarged and making too much parathyroid hormone, which will make your bones worse because it's sucking the calcium out your bones. And so that's when your doctor would put you on Sensipar to bring that down. And unfortunately, while you're in dialysis, that's allowed and is covered by your insurance, but after transplantation, Sensipar is limited. So for some insurances post-transplant, but for some patients, it may require that you may have to remove 3.5 of those glands because they're constantly working and now they've become autonomous. They're not listening to the rest of your body that says, I don't need any more calcium. They continue to make too much PTH, and so you would then have to have a parathyroidectomy, removing 3.5, leaving a half behind, or for some people, that half is implanted into the muscle in their forearm. Just in case it continues to enlarge, then you can easily go back and retrieve it or take some of it out so that you don't end up with significant bone disease. So thank you. I hope that explains that. Question is kind of a little bit complicated because when those glands become autonomous, they're no longer listening to your body. They're now low. Your phosphorus is normal, or your phosphorus would be low. Your calcium is normal, but now these glands are still saying, "Oh, now you got me going on making too much PTH, and I don't know how to stop." Think of it that way. So they're on the ride and they don't slow down, and so that ends up with surgery. So thank you for that question. Thank you, Katie and Pat and William, for coming on. Let me know if you have any questions. Miss Nancy put some interesting information in here, and that our first roundtable will occur on July 10th at 1 p.m. and it will be facilitated by the CEO. And so there will be a conversation on Medigap. So I encourage all of you to log on and ask your questions, listen to see what you can learn about Medigap and insurance from that standpoint. So again, thank you. I'm not sure where you are, but I think we are here in Delaware. We're expecting a storm, and I hope all of you are safe where you are. We've had some turbulent weather over the past weeks, but hopefully we'll get a reprieve and get some warm weather. It'll also be hot, so I appreciate that. So any questions, please let me know. Again, I said I'm Dr. Scanterbury. Can you discuss the dangers of becoming overheated for transplant patients? Very good, excellent. We know there's some heat coming along the way. You want to make sure that you are well hydrated. When the days are hot, we want to make sure that you are not outside, especially because you do not want, if you're on dialysis, it's maybe difficult to keep your fluid status down. So you want to freeze some grapes, use some, put some kind of drink in your ice cube tray so you can limit your water intake so that you don't get dehydrated. It becomes very important. If you are on a water pill post-transplant, you want to be careful that while you're out and about, that you may want to say, okay, I may not need this water pill today because I'm already dry. You've got to follow your signs and check your urine in terms of the color of your urine. You know, if it's very, very yellow and dark, you may be dehydrated. So you want to be able to say, okay, I urinated today? Oh, I haven't urinated. My output may be down. So be conscious of those things. So thank you for that question. Best items for dialysis patients to prepare for transplant. The biggest thing is make sure you are in good shape. We do, if you are over a certain age and have very little stamina, we can often send you to PT to increase your stamina and endurance. Transplant is just like another operation, but the goal is to get you up and out of bed the next day and walking. We want for you to be able to move despite that pain. Pain is not going to keep you in bed. You have to be able to get up and walk. You have to be able to take a deep breath. If you are trouble with breathing, you want to practice deep breaths. You want to be able to make sure that you have that endurance to get out of bed. It's always really disappointing to do a transplant and have someone be sent to rehab because now they don't have enough strength to walk around. So make sure you're in good shape. Definitely do all the things that you need to do to prepare. Even after you are on the list or about to get on the list, remember annually you have to make sure that your cancer screenings are up to date. Cardiac-wise, you want to make sure you're up to date with your stress tests, your echocardiogram, anything that's necessary. You don't want to have any infection. So if you think you have an infection, notify your transplant team, get it treated immediately. And because if they call you and you have an infection, you will not be called in for the transplant. And if you don't tell them and you arrive, you will be sent back home. So remember that. Albumin, what is it? How important is it? And how do we increase it? Albumin is a protein. It's a molecule that's we carry around, and it causes water to be attracted into your bloodstream. So it prevents you from a lot of edema. So albumin is your protein level. The more protein you have within your bloodstream, the more you will pull fluid from outside your bloodstream into your bloodstream. So it keeps you from developing edema. If your protein is low, then those molecules cannot attract fluid, and you may tend to have more fluid building up in your tissues. It's important for cell metabolism, for our brains to work, for our muscles to work, and so you have to look at ways to increase protein without necessarily increasing a lot of fluid if you're on dialysis. So you have to think about what foods are high in protein. Eggs. You may want to use some collagen powder, which not necessarily the protein powder that you make shakes with, because you then have to mix that with milk and all that stuff, which you're not allowed to because it'll make your phosphorus high. But you can do collagen protein, which will then allow you to have 10 grams of protein per scoop. Things like tuna fish or fish packs, sardines, things that you're allowed to eat that's not necessarily going to cause too much salt or other things that you're not, like potassium and stuff. So you have to talk to your nutritionist about how to increase your protein. If you're glucerna, if you are diabetic, if you're not diabetic, you may want to look at other drinks that are high in protein to add that protein to your diet. So you want to increase your chicken, your fish, your meat, so that you can get those appropriate grams of protein into your diet. So thank you for that question. Let's see, what am I missing? Thank you, Yolanda, for welcoming our ambassadors and all those who are here. So thank you guys for coming on. Again, my name is Dr. Velma Scantberry, and I am the medical consultant for Dialysis Patient Citizens Educational Center. And for those of you who are first time on here, I welcome you and thank you for coming on. And of those of you who have been on here before, thank you again for showing up. And so we talked about albumin, the dangers of becoming heated. One of the things that's important, next week is supposed to be a very hot week, at least here on the East Coast. So be sure to stay inside, especially when it gets past 90 degrees. You don't want to be out there unless you have to. If you do, make sure you have a way to cool yourself down. You can get little portable fans. You can get those fans that go around your neck. Anything to keep cool. Pour some water on your body if you think that you are getting exhausted, and make sure that you limit your intake, especially if you're on dialysis, so you have underlying heart disease. you have to be very careful about how much water you take in and how much liquid. So that is important. As we know, many of you may have restrictions on your fluids, so talk to your healthcare provider about what you can do. Like I said, try your best to use frozen drinks or frozen ice or frozen fruit. If you allowed watermelon, it may be helpful to make slushies of the watermelon and freeze them in small ice cubes that you can slowly use over time so that you limit the amount of fluid you take in. You want to take your medicines. If you exercise, you may want, and you walk outside. Sorry about that. We're having some connection issues here as the weather is getting bad. Sorry about that. And so I hope that you're still there. Sorry, apologize. So again, I'm back. And any questions? How often should you get? Let's see. Are you still taking new patients? How do you choose a nephrologist? How do we talk to? Or do we have to take the ones they give you? No, you can choose your nephrologist. If you don't like the one you have, oftentimes they may be in the same group. You may choose to have. You really want to have someone who is going to look after your best interest, who you can communicate with. And if you're not feeling comfortable, then I think it's important to have that discussion with them and really find someone that you feel is communicating well with you and sharing options with you. Think of yourself as the consumer. Your insurance is paying his bill, is paying your bill to him so he can make money. You deserve to have the best possible care. And if you have to change your doctor, then I say go about it. You can often ask your primary to make another recommendation because this is your lifeline. They're going to do the best. They should be doing the best for you and looking out after your best interest. You're the customer. Always remember that. Can you discuss home dialysis and it can help with some patients? Definitely. If it's the way to go because you want to be able to dialyze very often, we eat a few times a day, and so we accumulate metabolites. What happens as a result of that? Those metabolites need a way to get out. Normally, if you're functioning well, you urinate them out. If you're not, you need a way to get them out. We don't want to, just imagine if you weren't able to pee until every other day. Those things would stay in your body and provide toxic substances that affects your brain, your heart, urine itself. So the goal is how often can you cleanse your body of these waste products and metabolites. And so if you can do it on a daily basis, because we eat on a daily basis, that will keep your body in the best possible shape. So it can definitely slow down your heart disease because when you're dialyzing, hemodialysis, 3 days a week, you're accumulating a lot of weight that's hard on your heart. And so the downside of hemodialysis 3 times a week is that you end up with slow deterioration of your heart. So you want to talk to your nephrologist and those in your center about what you can do to perhaps do home dialysis. And I totally recommend it. How often should you get a biopsy after transplantation? There are certain centers that said yearly, but it all depends on your function. If you are within the first year, there are patients who would get biopsy because there's something abnormal. Your creatinine is high, your protein is high, your creatinine did not improve to the way you wanted it to be. You think it should be lower. You're looking for underlying rejection. You're looking for the development of antibodies. And so if I'm not pleased with your function, I may want to biopsy you to see, is there something missing? If I know this is a good kidney, a big kidney, and your creatinine should be 1, but now you're stuck at 3, I might biopsy you. But if I see there's nothing wrong with that kidney at creatinine 3, then we will slowly wait it out and see if that's the lowest you're going to get. If you came in and your creatinine is now higher than it was, then I may want to biopsy you. So the scenario is different for each patient, but in some programs you'll get an annual ultrasound to assess your kidney, make sure it looks good, check your creatinine, and so if there's no change, generally most patients do not get a biopsy. If you develop antibodies and there's certain criteria for biopsying, then those will come into place. Thank you for that question. What is the future of dialysis with a new pig kidney? Are we on board with this game changer? Remember, as soon as we develop something that's introduced, it takes years, for it to become, first you have to go through trials, and then you have to do a phase 2 and phase 3. And since your transplants are covered by Medicare, it takes a while for Medicare to approve anything that's new. If you have a pocket full of money and it becomes available, it will not be covered by insurance for quite some time, because Medicare has to be convinced that this is a viable option. And so that is, FDA, the whole 9 yards. Who knows what's going to happen to our system and how we are proceeding. But the goal is to make sure that once we do what's called a xenotransplant, that is from one species to another, you have to assure that there is no cross infections that was missed that will lead to detriments within the recipient. So the whole thing with pigs is they have to be bred in a sterile environment. We have to go through to make sure that there are viruses and bacteria that are common in other animals, that they can survive with it. That may not be the case with humans. So all those things have to be verified and make sure that it's safe before the FDA and the insurances will cover, so that you don't have those out-of-pocket costs. So thanks for that. Your insurance pays for whomever. Go for the best, or transfer clinics if necessary. Absolutely. Remember, you are the one paying that doctor, and so if there's only one group of nephrologists in your area and you're willing to travel, then it may be best to look other ways. So thank you for that question. We appreciate you. Thank you for being informative. I appreciate being here. Let's see. Any other questions? Thank you all. We are at 4:28, and one of the things I certainly appreciate the thank yous, because I switched to private practice I switched to a nonprofit seeing primary patients after coming out of transplant, because I felt that there were so many patients who felt that they were disrespected. Doctors were not listening. They did not involve them in the care. And I think it's so important. I tell patients, sorry, bad connection, but I was saying your physician is like a car. You don't buy the first car. You don't buy the first house you see. You find those that fit you and that you can be a good match for you, that fits your needs. And is that physician fitting your needs? You may live in an area that may not have options for you. If not, sit down and have a discussion with your doctor about your uneasiness, how you would like to participate in your care, or what the problems are, to see if you can find some common ground, because traveling may not be an option, but you are the customer. And as a provider, they should respect that. So thank you very much for that question. I hope I don't send you off to fire all your doctors, but they should be involved in you and at least giving you some options. So have a wonderful day, wonderful evening. Thank you so much, and God bless. See you next time in July.